So my remit tonight is to talk about common gynecological issues, and I'm obviously bearing in mind what you do and how they may present to you. It's lovely that I've been asked to speak about my 3 favourite subjects, so that's useful. I am going to speak about treatments because I think it's useful to put into context for you how we treat these common conditions, because I believe that many women don't come and see us as gynecologists because they're actually afraid of what I'm going to tell them. So we will speak a little bit about treatment, but I will try and concentrate on presentation, so I hope it will be useful. So we're going to start with heavy periods, which we call menorrhagia. Am I blocking the screen? I've been told that, can I stand this side then? Can I stand this side? Is that okay? Yeah, okay. Can you see? Can I stand somewhere where you can see? Okay, so heavy periods are really difficult to quantify because we don't really know, women don't really know what other people's periods are like. So if you ask a woman has she got heavy periods, it's often quite a difficult question to answer. And it's quite difficult for us as clinicians to assess exactly what heavy periods are. And so if you look at the working definition of the NICE guideline, and these guidelines tend to be quite pragmatic, it's blood loss which interferes with physical, social, emotional and material quality of life. And I'll go in some of the stories that my patients presented with heavy periods because it's quite interesting. So we know that 1 in 20 women between the ages of 30 and 49 consult their GPs per year about heavy periods, and I believe that's probably just the tip of the iceberg. And just over 10% of our referrals into general gynecology services in the trust are the primary problem is heavy periods. So when I'm speaking to women about their periods, I try and get a feel for how heavy I think they are by these sort of descriptive things that women tell me. So classically, things like flooding, so absolutely no control of their periods whatsoever, accidents, getting up in the night to change sanitary towels, missing work, being housebound, and you would believe the amount of women that I meet acutely after an on-call who have been admitted to the hospitals with very low haemoglobins, and they say to me, well, my periods have been like this for years. I just thought that was normal. Well, clearly it's not, because you're really quite unwell. I had a very interesting patient who came to see me just a few years ago who worked with David Cameron very closely, who's not famous, very much behind the scenes. And she described to me that in meetings with David Cameron, she used to take bin liners in her handbag so that she could sit on them so as to not to damage the chairs and his beds. I couldn't believe it. I couldn't believe it. And no word of joke, she was very anemic, and I was amazed that she'd lasted as long as she did doing things like that before she came to see us. We had a deep sea diver at St Thomas's whose boss sent her in because they were worried about the welfare of the other divers. Not just her. We had to escalate her treatment quite quickly to you know, there were great concerns about her job. So we see all sorts of interesting people suffering with these conditions that we can help them out with quite easily by doing many simple things. Women don't like to talk about their periods in the playground. Actually, they don't really like, I talk about periods all day long, but most people don't like talking about periods all day long. But they will talk about pain, and they will talk about backache, and they will talk about the fact they're tired. And women often think that heavy periods are just part of life. Oh, well, you know, I'm that age, really. I've had 2 children, my periods are meant to be heavy. But I'll go see someone about my back pain, but I won't go and see someone about my heavy periods. And the back pain and pelvic pain tends to get worse with heavy periods because the womb, the uterus, needs to often contract out very big clots when a lady's bleeding heavily. And so often people with heavy periods present with pain and not heavy periods. It's only when you ask them about their periods that you realise what might be causing their pain. And guess what? If you sort out their heavy periods, you might sort out their pain as well, or certainly can it. I think this is a huge factor in why women don't come and see us, and I alluded to it in the video. It's one of the things I've on about I've always been going on about it. Don't get me wrong, I'm trained in complex surgery, and I've enjoyed learning how to do hysterectomies, and I enjoy doing hysterectomies for women that need them. But not all women need a hysterectomy, and most women with heavy periods won't need a hysterectomy. And I think women don't come and see me because they think if I go and see a gynaecologist, they will tell me I need a hysterectomy. In the majority of cases, that's not how we do things anymore. As I said, here are the modern days of young female gynecologists giving other treatments other than hysterectomy. So, how do we treat them? In a moment, I've got a few slides on some. A lot of heavy periods, we don't know the cause. We call that dysfunctional uterine bleeding. Sometimes we do find a cause. So, for example, if we find a polyp or something like that in the uterus, we may need to take that out. But most cases, we don't find a cause. There are many oral medications that we can give for heavy periods. One of those is tranexamic acid. It's an antifibrinolytic that basically makes the blood clot a bit more, just so that you don't get as much flow. The contraceptive pill and straightforward hormones like that will often lighten periods. And many women come to me with heavy periods, interestingly, after they've changed their contraception. Classically, we don't do them as much anymore, but classically sterilisation. So women come to me saying, I've had these dreadful periods for the last 2 years, I can't understand it. And I go back and ask them what operations they've had. Oh, well, I had a sterilisation 2 years ago and I came off the pill. Ah, that's what's happened. You've come off a pill, which lightens your periods. You've now got something else in place for contraception, and that's why your periods have got heavier. The Mirena coil. I can't rave enough about the Mirena coil. It's an absolutely fantastic addition to our treatments in gynecology services. We use Mirena coils for everything in gynecology apart from infertility, because it's obviously a very good form of contraception. Although it does have a small place in infertility as well, but I won't go into that. I've got some pictures of it shortly actually. It's a small coil which fits in the uterus. It has the hormone progesterone on it, which thins down the lining of the womb. It's fantastic for contraception. It's fantastic for heavy periods. It's fantastic in HRT, which we're also going to a bit later. Endometrial ablation and hysterectomy are both surgical procedures, which I'll talk about shortly. So this is what I was talking about with, so women that get to, by the time women come and see me with heavy periods, I will have asked them to have a scan. So I take their history, ask them the questions that I need to ask them about what's happening to their life, and do they carry bin liners around in their handbags for their meetings and things like that. And then I'll also have information about scans. Polyps, I've got a little pointy thing, are just mostly benign, non-cancerous lesions that can grow in the womb. They're really, really common. They cause heavy periods, they cause bleeding between periods. They're quite troublesome, and I spend a lot of time removing them for many women. Fibroids are very similar to polyps. They tend to be a bit bigger and a bit broader base. And if they're poking into the cavity like that, we can take them out like polyps. If they're in the wall of the womb, we remove those surgically by making the cut on the abdomen, or more commonly now actually, we do them laparoscopically by keyhole surgery. So if I'm going to remove a polyp or a fibroid from inside the womb, we can put a camera inside the womb, a small camera from down below, have a look and take out the polyp at the same time. We do those at the Spire under general anaesthetic as a day case procedure. You come in at lunchtime, go home in the evening, sorted. Much better quality of life after that procedure. So here's just some pictures of microgynon, one of the most common combined pills that we use, tranexamic acid. I tend to use tranexamic acid in combination with other treatments, and the small Mirena coil there that you can see. Fits into the uterus. very easily in most women, particularly if they've had children. But if you haven't had children, you can still have one, we still fit them, it's not a problem. The strings just poke out into the vagina. Poke is a bad word, isn't it? But they're there in the vagina so that we can remove them easily. It doesn't interfere with sexual intercourse or anything like that. They are licensed for the treatment of heavy periods and most other things for 5 years. So that they last quite a long time as well. And particularly good in the perimenopausal period, just to get women through that time leading up to the menopause before their period stops if they're having trouble. No short endometrial ablation, it's a procedure that's really, really taken off in the last 5 to 10 years. So this also is a day case procedure that we do under general anaesthetic. It takes me as a surgeon about 5 minutes to do it. It's a one-time procedure and uses radio frequency to burn down the lining of the womb. The difference with obviously with the Mirena coil is you can take a Mirena coil out and your fertility returns to normal straight away. I would contemplate doing an endometrial ablation for anyone that wanted further family, as we burn down the lining of the womb and it doesn't exist anymore, so it's very difficult to get pregnant after having one. Doesn't mean to say it's impossible, so we still advise women to use contraception, and I will often do an endometrial ablation and insert a Mirena coil at the same time because of that. Belt braces, I call it as well. So, of course, despite my mantra about if you come and see me, not everyone's going to get a hysterectomy. Some people do, because they either have pathologies that we can't treat with anything else, such as an early cancer. It is really unusual to present with heavy periods with endometrial cancer. Very unusual. We do see it sometimes. It's very rare, less than 1%. Most women with a cancer of the lining of the womb will present with postmenopausal bleeding, but it does happen with some. So obviously, for some pathologies like that, we may have to do a hysterectomy. But even if we need to do a hysterectomy, it's still not the big operation that we used to do days of old. And the majority of them we will do by keyhole surgery. There's no reason why we can't leave the ovaries in the majority of cases, and in some women we also leave the cervix. So this major surgery is just not as major anymore. And our patients stay in one night and they go home the next day. Here's me operating with one of my friends, Oliver Chapat, who I work with very closely and who trained me. And this is just a diagram of the incisions that we make. Actually, I made the vertical one in real life as well. It's neither here nor there, is it? But the point is, they're very small, and you wouldn't believe that a lady had had a hysterectomy if you look at their abdomen after a keyhole operation. So that's a quick run through on heavy periods. I hope that's okay, and we'll swiftly move on to endometriosis. So endometriosis is a condition that I spend a lot of time treating. We are locally an endometriosis centre, and we take on and therefore take on a lot of endometriosis work from around the country because the operating is quite complex. And we've got a setup within the Trust and at the Spire where we work in a multidisciplinary team with doctors such as Ali Henderson and the colorectal surgeons, because endometriosis can affect women in all sorts of ways, which we'll go into. So what is it? Endometriosis is a condition where we see cells from the lining of the womb deposited in the pelvis. And it causes it, the main thing it presents with is pain. Which is why it's relevant to you. There used to be a thought that endometriosis was caused by what we call retrograde menstruation. There was this thought that instead of all of your period blood coming out into the vagina to the outside well, that some of it would move up through the fallopian tubes and get deposited in the pelvis. It's quite a nice idea, it's quite a nice way to explain it to patients, but actually the latest evidence is that that's just not the case. So in fact, we're born with endometriosis, because we've now found endometriosis in some post-mortems of neonates, babies, and then it's the hormones as we go through puberty and our reproductive life, the up and down hormones that causes the endometriosis to grow. Most endometriosis, certainly most severe endometriosis, tends to be a problem in the 30s and 40s, and more superficial endometriosis presents in your 20s. But it's an incredibly common condition, seen in about 1 in 10 women. I think the challenges about endometriosis are this, is that women can have a very small amount of endometriosis and yet be debilitated by the pain. And other patients can have terrible endometriosis and have very few symptoms and present with a kidney that's not functioning because the endometriosis has wrapped itself around the ureter, the tube that connects the kidney to your bladder. And that makes it very difficult to manage, The key is to listen to the patients actually and treat their symptoms. It's quite, really, some might say simple, but it gives us a lot of dilemmas about what we're going to do and how radical we have to be in our surgery. So, what I wanted to show you is, because you don't get to see these pictures, is this is a normal pelvis. So if I put a laparoscope through someone's umbilicus and I have a look into their pelvis, this is what we want to be seeing. So it's a lovely, lovely pelvis. You don't get one better than this. So it's a lovely, normal size uterus. This is the left fallopian tube. This is the right fallopian tube. Just get my size right. I did get my size right. That's good. You can just see the right ovary under here and the left ovary under here. This is one of the ligaments that supports the uterus. The round ligament here and here. The bladder lies in front. You can't really see it, and I'm sure I ought to live for a year or two. Mr. Henson's there, but I can't really see it, but it'll be a lovely cycle. But I promise I do for every single operation I do. So, again, this is just us lifting up one of the tubes. That's the tube on the left side, and that's the left ovary. And this is a tube on the right side and the right ovary. This is the vessels coming in that feed that ovary there. It's lovely, there's no spots in it. I'm just about to show you some pictures of some endometriosis to compare. So this is what I call some very superficial endometriosis. It's quite easy to miss if you don't look hard enough. But just some little red patches here. And probably just a little bit more here. Surgically, we can, what we call, ablate or burn endometriosis, or we can excise it or cut it out. And these days, more and more now, we tend to excise even the most superficial endometriosis because it takes it out of the equation rather than burn it away. So we tend to this lining, if you like, of the abdomen and uterus called peritoneum, we tend to excise it. You can see it getting a little bit more interesting now. This is some endometriosis on the right pelvic sidewall. I'd probably describe this as deep infiltrating endometriosis. I wouldn't call it a nodule, but it's penetrating beyond 5 millimetres of the peritoneum, and you definitely need to excise endometriosis like this, and this will cause, probably likely to cause more severe symptoms. This is the left ovary. That's a normal right ovary there. The endometriosis isn't too bad. You can see the peritoneum looks quite clean. But this is a cyst which will be about 6 centimetres. It's been opened up and the material's just oozing out of it. Sorry, I know people are eating actually. I didn't really think about that. But I'm sure you'll have worse pictures, won't you? I think so. So this is, so eat up, because yes, it'll get worse in the second presentation. So we call the fluid that we see in endometriomas chocolates. We call them like chocolate cysts because it looks like runny chocolate that's running out. And obviously a cyst of this size tends to cause a lot of pain and needs to come out. You'll hear us talk about rectovaginal endometriosis, and the reason I want to speak about rectovaginal endometriosis is it's the endometriosis that really causes the pain. It causes a lot of back pain. It causes a lot of pain during intercourse. It causes terrible pain when patients open their bowels. If patients report to me they have pain on the bowel opening during a period, I instantly suspect they've got this type of endometriosis, the worst type of endometriosis, sticking the rectum to the back of the uterus. And it's the most challenging endometriosis that we have to manage. And you can see the difference, can't you? You must be able to see the difference in this compared to that earlier photo that I showed you. This is quite inflammatory endometriosis, isn't it, as well? It looks quite sore, it looks quite inflamed. The rectum's pulled up to the back of the uterus. You can see the uterus sacrals are pulled in. it's really quite nasty, and you get these sort of blebs of endometriotic material. This all has to be excised, and we aim to excise it, make the patient's endometriosis free, hopefully pain free. It's not simple surgery, it's really quite technically difficult surgery, and some patients will require their bowel to be resected in operations like this. And here's the wall. And you can see the bowel really pitched up here. And it's really difficult for us sometimes to cut all this bowel off safely. And we tend to do these cases with the colorectal surgeons as well. But it is difficult because sometimes I see endometriosis like this, I'm going in for another reason, perhaps something like infertility, because the lady can't get pregnant. She's not really in that much pain. And then it's very difficult for us to decide exactly what we do to the endometriosis. So specific symptoms of endometriosis, your classic endometriosis patient has pelvic pain, but that's cyclical. It's associated with their periods. It tends to start a few days before their period and be terrible in the first few days of their period, and then it tends to die down. It is normal to get a little bit of pelvic pain, and again, it's difficult, isn't it? Because we don't know what everyone else's pain is like. It's difficult to assess sometimes. Pain during intercourse, as I've mentioned to you, pain with bowel opening and infertility. And some patients presenting to their GPs will be fine on just some painkillers or hormonal treatments such as the pill. If they're not trying to get pregnant, it's absolutely fine to say, you might have endometriosis. We know that the pill helps endometriosis, so why don't we just try you on the pill and see how you go? We don't necessarily have to laparoscope you and have a look. We do ultrasounds for anyone with pelvic pain to look at fibroids, cysts, and not all endometriosis can be seen on a scan. However, if it's very severe, we do tend to see it on a scan. But you can't see all endometriosis on the scan, which is sometimes when we laparoscope you, we just have a look. And surgery that we've mentioned. There's no doubt that the surgery that we need to do in the end for women with severe endometriosis tends to be, in the end, a hysterectomy and BSO. And some of our treatments for endometriosis will just get them through their hopefully fertile years, and then at the end we tend to do pelvic clearance to try and cure their endometriosis in the end. That's it, endometriosis. I will take it, yes.
Does the excision of the lesions, do they come back? They then reoccur after surgery?
So I think the question said, does excising it, get rid of it, it shouldn't come back? Is that,
no,
does it come back?
Does it come back?
Does it come back? So it depends who excises it. Joking apart, so academically, if we excise all endometriosis, it shouldn't come back. That said, I have laparoscoped some of my own patients, again, who I'm absolutely sure I've taken the endometriosis out, and there is some, again, recurrence, or there's some that I've missed, whatever. So it's difficult to know, but so the answer to that is sometimes, I suppose, without trying to sound like a politician. And what we find, if we think about babies having endometriotic cells in their pelvis, what is it where you go from a relatively normal pelvis to a pelvis all glued up? Because you're not born with a glued up pelvis like some of those pictures. And it's the hormones, it's cyclical hormones that cause endometriosis to grow. And that's where the theory of the pill comes in, is that if endometriosis is sensitive to hormones, why do we give hormones to treat it? Well, it's to stop that, and it's to make hormones do that. And that, again, is why after the menopause, endometriosis tends to drop down, because your hormones are just low, and the same is the cyclical nature of hormones is the problem. So often we will excise the endometriosis and give some hormones to sort of drop down anything that's left. But, so, yeah, a bit of a grey answer to your question, but ideally it shouldn't come back. The other thing that causes pain after endometriosis surgery is adhesions. So we would go in sometimes to have a look to see if there's any adhesions that we can divide scar tissue after the surgery. So, yeah.
If it was some of the more advanced presentations,
yeah,
so right, the glued up pelvis,
yeah.
And so if it isn't,
yeah,
and it is that bad,
yeah.
is it dangerous to the patient in any way? So if they
It's a really good
have
question.
intervention,
Yeah,
could they,
yeah.
without having it treated, are they going to
Yeah.
other areas of
Sure.
disease?
So that's a really good question. So the question I hope everyone heard is it if you've got bad endometriosis and you're not symptomatic from it, do you need treatment? So I think the answer to that is no, because the treatment you need to get rid of terrible endometriosis like that is major surgery. And if you're not symptomatic from it, then it would seem it's just not, why would you do that? It doesn't seem right. It's not cancer. It doesn't spread like cancer. That said, we do see an increase in clear cell cancers of the ovary with large endometriomas. So women that have an endometrioma is a cyst on the ovary full of endometriosis. Sorry, I must be careful about my medical jargon, I do apologise. I've got a lady at the moment who's got dreadful endometriosis, but she presented with heavy periods. She didn't really have much pain, but when I scanned her for heavy periods, it showed quite complex cysts on the ovaries. But and I said to her, she'd had her children, I think we should probably, take it out. She said, I don't want you to take my ovaries out. I thought, well, just taking the cyst out isn't going to help the disease. And so what we've agreed to do is just monitor her ovaries. And certainly if she has cysts like that after she's been through the menopause, then I'll advise that they do come out because of the risk of small increased risk of cancer. But while she's premenopausal, we will leave her as she is, and I just treated her heavy periods with an endometrial ablation, which I spoke about earlier. So the answer to that is, if you've got severe endometriosis, does it need treating? If you're asymptomatic, no, it doesn't need treating. You should be treating asymptomatic endometriosis. Yeah. Right. Moving on to menopause. How am I doing for time?
About 15 minutes.
Okay. There's 7 witches of the menopause. Itchy, bitchy, sweaty, sleepy, bloated, forgetful and psycho. A few years ago, I added this slide to a presentation, and my husband, who was checking the slides with me, looked at this and said, I think you've got that. Over the weekend, when I added this slide to this presentation, my 3-year-old little boy said, which one of those are you? So I'm not going to put these slides in anymore. So we're joking apart, because it's really not a joking matter for most women. The menopause can be a very, very challenging time for many women. Around 8 out of 10 women will get some sort of menopausal symptoms, many years before they're actually menopausal, and on average, somewhat 4 or 5 years after they've stopped their periods. And for just over 10%, their menopausal symptoms will last for 12 years after they've been through the menopause. It's a really big problem. And in fact, I was speaking earlier and saying I didn't really have a lot of formal training in the menopause. I didn't go and seek training for the menopause when I was a junior doctor, but actually the menopause has come to me. Well, not me personally yet, but what I'm saying is that patients come to me about the menopause, and I've really had to learn a lot about it over the years to help women. It's a really, really difficult problem, and women need help with it. And there's lots of different reasons as to why over the years women haven't been helped with it appropriately. There's lots of confusion with what the definition of the menopause is. So the actual medical definition of the menopause is a year without periods. So it's a retrospective diagnosis, if you like. The average age in this country is 51. But as I've mentioned to you, many women in their 40s will have menopausal symptoms way before their periods stop. The most common being night sweats. So these are the sort of common symptoms that you'll hear about, friend in the office that needs to keep the window open because she keeps getting hot flushes all the time, or you're moody because you're menopausal. Sleep disturbance is a huge problem, sleep disturbance around menopause. And I remind women, the other group of women I see with sleep disturbance are those that just have babies. It's a form of torture, isn't it, sleep deprivation in some countries? And to try and live your life when you can't sleep is very, very difficult. Often problems with intercourse, often due to a dry vagina, which these problems are quite easy to solve sometimes. Hair changes. I think there's definitely a gap in the market for a shampoo for menopausal women because lots of women talk to me about hair loss. I saw a lady a few weeks ago and said, if there's one thing I could make better for you, what would it be? And it was her hair. I haven't got specific things for hair, but a few little tips and tricks, but we don't have anything specific on the market. And funny enough, period problems. So the perimenopausal time, the time leading up to stopping periods can be a real problem. They can become quite irregular and erratic and unpredictable and very heavy. And we can use the same treatments that we've spoken about earlier for heavy periods in perimenopausal women. There are other more subtle symptoms of the menopause that I wanted to sort of bring to your attention that often get missed. I think lots of women accept the fact that they will have hot flashes and night sweats, but they don't know why suddenly they feel really down all the time, or that they're really anxious about things that they weren't anxious about a few years ago. And they will often present to their GPs with these sorts of things and get started on antidepressants. But it's often not antidepressants that they need, it's just some HRT. I see this a lot, more and more now. Muscle and joint pain is a huge issue in the menopause. And we don't really know why, but lots of women, particularly with foot and ankle pain actually, but generally just lots of aches and pains with lack of estrogen. And all of these sorts of things have a massive impact on women's relationships, often with their husbands, their relationships with people at work. They just can't handle their jobs anymore, and it's a really difficult time of their life. And the other thing is, often women around the time of 50 have teenage daughters who are having puberty at the same time. And it's a complete nightmare for people at home, dealing with all these hormonal changes and dealing with the consequences of erratic hormones. Hormone replacement therapy has been a really controversial thing in gynecology. I qualified in 2003, and there were two big trials around that time that were published that slated HRT. And I grew up as a young gynaecologist with my seniors telling me just don't give it because we're not really sure where we are with it. There's this huge scares about breast cancer. And a generation of women were really denied HRT unnecessarily because of these bad papers and bad research. So what are the benefits of HRT? HRT instantly deals with the witches. So it deals with all those things that are acute about the menopause, such as night sweats and hot flashes. And it will also deal with those more subtle symptoms, such as anxiety and depression and muscle and joint pain. And let me tell you, I spent many years learning complex laparoscopic surgery, and my happiest patients are those that I write a prescription of HRT for. They really are the happiest patients. We know that HRT prevents osteoporosis, and we use it to treat osteoporosis as well, and it can prevent heart disease, particularly in women under 60. So what are the risks of HRT? Because everyone talks about the risks and not really the benefits, and it would be wrong of me not to talk about the risks of HRT. Women that still have a womb intact need something called combined HRT. So it's estrogen that you need in the perimenopause and the menopause. It's the estrogen that tackles the 7 witches. It's the estrogen that prevents osteoporosis and treats osteoporosis. Progesterone that we need in combination with it is merely there to protect the endometrial lining. So if I gave estrogen-only HRT to a woman, her lining would thicken up and that would cause problems and can in the long term cause cancers. So if women have a uterus in situ still, they need combined HRT. If for some reason they've had a hysterectomy over the years, they only need estrogen HRT. Estrogen only HRT does not cause an increased risk of breast cancer. I'll say it again. Estrogen only HRT does not increase your risk of breast cancer. It doesn't. It's quite conclusive. There's a nice guidance about it. There's lots of research about it. Combined HRT, estrogen and progesterone, does cause a small increased risk in breast cancer. It does not increase your chance of dying from breast cancer. Not a great statistic because nobody wants breast cancer, but the fact remains it doesn't increase your doesn't increase your chance of dying, basically. If women increase their exercise and reduce their alcohol, that brings their risk of breast cancer beyond baseline. Then if taking HRT. So what I'm saying is, if a woman comes to see me and I give her a prescription of combined HRT and she exercises more and reduces her alcohol, I have actually reduced her chance of getting breast cancer. So the point is there are other risk factors that are more important than HRT, and women should not be denied HRT because of the risk of breast cancer. Now obviously, I can see hands going up all over the place. There are a group of patients that aren't suitable, and for example, if a woman has had a breast cancer which is estrogen receptor positive, then it's very unlikely that we would prescribe HRT. But I wouldn't ever say no and never to anybody after a discussion, because sometimes at the end of the day it's about quality of life. Did you want to ask somebody for that hand up? Yeah.
Yeah, just if there is a genetic history of breast cancer, then notwithstanding that you said that you can lower by using alcohol, would you still?
Yeah. So the answer to that is we assess anyone on an individual basis, but let me just tell you that the national guidance about patients with BRCA, for example, those patients that come to me asking me to remove their ovaries because they are BRCA positive, the evidence is quite clear that we give them HRT. So in their backgrounds, they've already got background risk, but if I'm going to remove their ovaries, and most of them will have their ovaries removed in their late 30s, early 40s, we give them HRT. There's absolutely no question around there. Because it's very detrimental to their health to lack estrogen in other ways. And don't forget, if we do a hysterectomy at the same time, I won't increase their risk at all anyway. And they're another group of women that have been denied HRT for many years. It should not have been denied there.
It's just that there are so many patients who actually won't entertain the idea of HRT because they believe in this.
Absolutely, which is why I spend my evenings talking about it. It's the most common subject I talk about now. And why this all comes to us now as gynecologists. And that's what I want. This is what we'd love to do, is open up the discussion. There are women that won't let themselves think about HRT because of these perceived risks, which are just not true. So we're working very hard. Have a read of my Twitter, always tweeting about it, trying to spread the word. Clots in the leg and lung, DVT and P, are the other big risk of stroke actually as well. It makes them more clotty. Only with oral HRTs. So we now give HRT in gels and patches. So estrogel is my favourite form of estrogen HRT. It's a gel which you rub on your arm, 2 pumps, 2 to 4 measures daily. That does not increase your risk of DVT and PE, and does not increase your risk of stroke, but oral estrogens do. So we're moving away from giving oral estrogen now for HRT, and we're giving patches and gel. I prefer the gels because the patches often can come off during a night's sweat and end up on your husband, and they're definitely not going to be there. And they also can cause quite a lot of skin reactions as well, so I found the gels much better tolerated. It also looks like you've been to the spa and had a nice treatment, rather than you've gone to a gynaecologist to talk about your menopausal symptoms in your dry vagina, which I think is a huge thing in the menopause. It's very difficult for women to accept these symptoms and accept what's happening to them. That they're accepting that their reproductive life has come to an end and they're getting older, and that is a very difficult thing to accept. As a young woman, 51 is very young, and these things are very difficult for women to accept. So, I'm quite pro-HRT, very pro-HRT. So I think that's it, actually. So, yeah.
Could you use the cords? What the cords were? well?
Absolutely. So that's one of the many uses of the Mirena coil. So it is licensed to use as the progesterogenic component to combine HRT. And it's fab actually because perimenopausal women often have terrible periods. So it acts to thin down the lining, help their period. Perimenopausal women need contraception. It's a very good contraceptive, and it provides the progesterogenic opposition to the estrogen HRT as well. So I fit as one of the main reasons I fit Mirenas now for
Even
HRT.
after even after their periods have stopped?
Absolutely, we can use it postmenopausally, yeah. Pop them in all the time for that, yeah. As I said, there's nothing I don't use them for actually. They're wonderful. Anything else? Yeah.
Do you recommend the pessary?
The estrogen pessaries, yep, so we do. So particularly good for vaginal symptoms, dry vagina, and a condition called atrophic vaginitis, which is really common postmenopausally. And I use those in combination with the systemic HRT, if you like. So, and lots of women don't want to go on HRT because it's got a lot of bad press, or they can't really go on HRT because they do have a true contraindication, such as an estrogen-positive breast cancer. We do give topical estrogens in those patients because the absorption is so minimal, but it does help local treatment. So yeah, I use vaginal estrogens, creams or pessaries a lot. Also helps with recurrent UTI due to atrophic vaginitis.
Is there an actual stopping point, or do you just carry on?
Yeah, that's a really good question. Yeah. So certainly for those that have had a surgical menopause or an early menopause for an unknown reason, there's absolutely really no increased risk up to the age of 51 when your natural hormones would decline anyway. And 5 to 10 years after the menopause, we're very comfortable. And I do have a group of much older women on HRT. You just can't get them off it because as soon as they come off it, they get symptoms. The risks actually with HRT, the stopping and starting HRT is not good. It's not good at all because your risks are highest when you first start it. So stopping it and restarting it is not good. So it's a really difficult thing to decide when to stop. But I think women, what they tend to do is naturally sort of wean themselves off. But the British Menopause Society don't have a cut-off with regard to when to stop HRT. So we do it very much on an individual level. But we do, the nice guidance is that we see women yearly that are on HRT for assessment, ongoing assessment of their risk factors. Because we wouldn't want anyone to continue it if they, for example, had a breast cancer or something